Hello everyone, my name is Jonathan Steven Andrade Bazan. I'm an amazing student at UCSG University, and I'm going to talk about preserved renal allograft function and the PD-1 pathway inhibitor Nivolumab. Let's start with the definition. Immunotherapy is the use of drugs to boost a person's immune system to effectively recognize and destroy cancer cells. Various types of immunotherapy can be used to treat kidney cancer.
One of the most exciting approaches to cancer immunotherapy involves releasing the natural brakes that keep the immune system in check. This approach, called checkpoint blockade, takes advantage of the fact that the immune system already knows how to fight cancer. It just needs a little help. The immune system's main cancer fighters are called T cells. T cells have receptors on their surface that do different things. Some act like a gas pedal on a car, telling the T cell to go. Others act like a brake, telling the cell to stop. Drugs called checkpoint inhibitors release the brakes, allowing the immune system to step on the gas and fight the cancer. Many cancers have learned to hijack these same immune brakes to avoid destruction. They make a molecule that engages the brakes. Checkpoint inhibitors block this interaction as well, robbing cancer of an important defense. Several checkpoint inhibitors are currently FDA approved for the treatment of melanoma and lung cancer. The drug Yervoy blocks a checkpoint called CTLA-4. Two other drugs, Opdivo and Keytruda, block a checkpoint called PD-1. Many cancers respond to checkpoint inhibitors, and the future looks very bright for this important class of immunotherapies. Created by the Cancer Research Institute, the leader in immunotherapy. To learn more about immunotherapy and about clinical trials, visit our community for patients and caregivers at theanswertocancer.org.
Let's continue to application in medicine. As important feature of the immune system is the ability to prevent cells from attacking the normal cell in the body. To do this, they use checkpoints that are protecting immune cells that need to activate or deactivate to ignite the immune response. Sometimes kidney cancer use this checkpoint to avoid being attacked by the immune system. Still, this drug targets protein at the checkpoint, helping to restore the immune response against the cancer.
Of locally advanced or metastatic lung, melanoma, and kidney cancers, and is being studied for many other cancer types. Opdivo is the trade name. Its generic name is Nivolumab. Opdivo is made by Bristol Myers Squibb. Opdivo is a new type of cancer treatment called immunotherapy. Basically, it activates the immune system from being dormant. Our immune systems are dormant until there is a need to fight foreign bodies, like an infection. Because cancer hides from the immune system, it doesn't know it needs to go to work. Opdivo is an antibody that binds to the protein called PD-1 on T cells that live in our immune system. T cells are like a car ignition that gets the immune system off and running. This stimulates the immune system to find and kill cancer cells. Opdivo is given intravenously on one day every 2 to 3 weeks in cases of advanced or metastatic cancer, but not in early stages of cancer at this time. Opdivo is used for the treatment of lung, melanoma, and kidney cancers. In lung cancer, Opdivo is used in advanced or metastatic non-small cell lung cancer that has worsened after treatment with previous chemotherapy, or has worsened after treatment with previous targeted therapy. For melanoma skin cancer, Opdivo is used in advanced or metastatic melanoma. In kidney cancer, Opdivo is used in advanced or metastatic clear cell kidney cancer that has worsened after previous treatment. Opdivo helps people live longer without the cancer growing, and live longer overall than if they did not take Opdivo or took other cancer medicines instead. Some common side effects that I see in my patients taking Opdivo are feeling tired, pain in muscles, bones, and joints, loss of appetite, nausea, cough, constipation, shortness of breath, diarrhea, or rash. Some rare but serious side effects can be inflammation of organs, such as the lung, intestine, kidney, liver, and brain. Opdivo may also have an allergic reaction or problems with the thyroid gland. Based on its mechanism of action, Opdivo may cause fetal harm when administered to a pregnant woman. Women should not become pregnant while taking Opdivo. Opdivo is a new cancer drug that stimulates the immune system to fight cancer. Opdivo gives us hope for living longer.
Let's continue to pros and cons. Pros and cons. Pembrolizumab and Nivolumab are drugs to attack the PD-1, a protein in immune system cell called T cell that normally help prevent the cell from attacking other cells in the body. By blocking PD-1, this drug boosts the immune response against kidney cancer. This can often decrease the size of the slow growth some tumor.
Many genetic and environmental factors can cause tumors to form. For instance, UV radiation from the sun can damage DNA and other structures in melanocytes, which are the pigment-producing cells in the skin. Chronic damage to melanocytes by UV radiation leads to most cases of melanoma, which is a type of skin cancer. As melanomas grow, they can eventually spread to other sites in the body, such as the lungs and liver. The cells of the immune system are continuously monitoring our tissues. Natural killer cells, or NK cells, sense stress-associated molecules on damaged and cancerous cells. Dendritic cells, or DCs, activate cytotoxic T cells, which can then sense tumor-associated antigens using their T cell receptor and other co-receptors. Once activated, NK cells and cytotoxic T cells release perforin and granzymes. These molecules punch holes in the surface of the tumor cells, causing them to die by apoptosis. Helper T cells support these responses. They help DCs to activate cytotoxic T cells, and they produce cytokines such as interferon gamma that recruit and activate more NK cells. As the tumor evolves, genetic changes occur that can give some tumor cells a survival advantage. This means tumors are often heterogeneous. For instance, tumor cells may no longer express the molecules that are sensed by the killer immune cells. As the immune system continues to kill the tumor cells it can recognize, the cells it can't sense become more prevalent. This is immunoediting. It leads to the emergence of a tumor that can't be detected by the immune system. Some tumor cells actively suppress T cells by expressing inhibitory molecules such as PD-L1. PD-L1 binds to the PD-1 receptor on T cells and deactivates them. This is an immune checkpoint. In addition, tumor cells can attract immune cells that suppress the activity of other immune cells, thereby supporting tumor growth. These immunosuppressive cells include regulatory T cells and certain types of myeloid cells. Therefore, the tumor microenvironment is like the scene of a battle between two opposing immune responses. One side of the immune system is attacking the tumor, while the other side is helping it to grow. Scientists are developing immunotherapies to help strengthen the immune attack. One approach is adoptive T cell transfer. Cytotoxic T cells taken from patients with melanoma are selected for their ability to attack tumor cells. The best killers are infused back into the patient. Treating patients with cytokines, such as interleukin-2 and interferon alpha, can also boost the activity of anti-tumor immune cells. An alternative approach is to target the immune checkpoints. For instance, antibodies that bind to PD-1 stop this molecule from switching off cytotoxic T cells. Another immune checkpoint being targeted is CTLA-4. Blocking this molecule helps DCs to drive anti-tumor T cell responses. Not all patients will respond to these immunotherapies, and some responses will be delayed. Combining immunotherapies with chemotherapy or radiotherapy can lead to a better response in some patients. Immunotherapies can themselves be combined. For example, PD-1 and CTLA-4 blockade can improve responses when administered in combination. Activating the immune system has risks. Some patients develop harmful side effects when their immune system attacks healthy cells. Nevertheless, there have been encouraging results from clinical trials. This animation has focused on melanoma, but it's becoming clear that immunotherapies can be used to treat many different types of cancer.
Nivolumab can be used with the target therapy drug Nivolumab as the first treatment for people who have advanced kidney cancer. Nivolumab can be used in people whose advanced kidney vein to grow again after target therapy drug treatment and has been shown to help people live longer. Issue applied in Ecuador. The new study were based on the different approach, combining the two strategies, a VEGF inhibitor such as axitinib and immune checkpoint inhibitor that had each be effective, each independently, for the treatment of kidney cancer. The study used different immunotherapy drugs, but were otherwise very similar. In both studies, more than 800 patients with treatment in advanced clear cell renal cancer were enrolled.
Like in many other diseases then, the checkpoint inhibitors come in, and here we have now two that have been not IRB, but FDA approved, after previously having been IRB approved for clinical investigations. And that is pembrolizumab and nivolumab. And those two agents are now available. They are active. And of course, we don't have direct comparisons. So the trial setup is a little bit different for the two of them. I will start with nivolumab because I think that that is a definitive phase 3 trial where patients who had failed a platinum-based regimen within 6 months of initial treatment were then randomized to nivolumab or a standard of care that the investigator could choose from, second line, in other words, after platinum. And that could be docetaxel, methotrexate, or cetuximab. So it was investigator's choice. And in that direct comparison, the checkpoint inhibitor was superior for overall survival. And it was also superior, but not immediately. There's a fairly sharp drop-off in curves, but then a separation of curves for progression-free survival. So it is the picture we've seen in other diseases that many patients don't benefit. In fact, probably the majority don't benefit, but those who do are benefiting enough to lift the entire survival curve to be superior. And furthermore, if a given patient responds, it can be for a long time, certainly much longer than what we've observed in chemotherapy-based regimens.
Nivolumab can be used in a targeted therapy drug axitinib as a first treatment for people with advanced stage kidney cancer. It is administered every 2 weeks by intravenous infusion. And finally, conclusion. Inhibition of immune checkpoint would be the use of an antibody targeting programmed cell death PD-1, a monoclonal antibody against cytotoxic T lymphocyte-associated antigen 4, has been used clinically in patients with various types of cancer. In the limited number of report cases in which this antibody had been used in patients who had undergone kidney transplantation, this agent has been associated with a cell-mediated antibody-mediated rejection.
So I'm presenting the Checkmate 025 clinical trial, which is a phase 3 clinical trial that randomized previously treated patients with metastatic renal cell carcinoma to either treatment with Nivolumab, an immune checkpoint therapy agent, or everolimus, which is a standard of care agent. We randomized over 800 patients, 410 in the Nivolumab arm, 411 in the everolimus arm, to treatment with a one-to-one randomization, so that patients got treatment with either Nivolumab or everolimus. And the patients were treated until disease progression or until toxicities that they could not tolerate the drug. So what we saw was that the Nivolumab-treated patients had an overall survival benefit of 25 months for the median overall survival versus the everolimus-treated patients who had an overall survival benefit of median overall survival of 19.6 months. This was statistically significant, meaning that the Nivolumab allowed patients to live longer and provided the survival benefit. Currently, most of the patients who are receiving treatment for metastatic renal cell carcinoma in the second-line setting are receiving agents to target the tumor cells, and these are sort of tyrosine kinase inhibitors or anti-angiogenic agents. And what we're trying to say is that an immune checkpoint therapy agent can also be beneficial and provide a survival benefit. Most of the other trials also looked at progression-free survival. This is the first time in a phase 3 clinical trial that we're looking at overall survival, and that is really the gold standard for saying whether or not patients are doing well with a therapy. And so for what we're saying is we have the potential now for a new therapy that can give patients this survival benefit. So the adverse events were what we would normally expect with Nivolumab and have been previously published. We did not see any new safety signals. What we did see was that there were fewer high-grade adverse events, the grade 3-4 adverse events. There were fewer of those in the Nivolumab-treated patients than the everolimus-treated patients. And there were no treatment-related deaths with Nivolumab. I think that we have a new treatment, hopefully, that we can think about for our patients, that we can think about an immune checkpoint agent now in Nivolumab being hopefully considered as a treatment option for patients who were previously treated with metastatic renal cell carcinoma. We don't know what's going to happen in terms of approval, but it was given a designation breakthrough status, so we hope to see that as now a new treatment option that can give our patients not only a survival benefit, but hopefully durable survival benefit. Absolutely. So currently, Nivolumab is being combined with another immune checkpoint agent, Ipilimumab or anti-CTLA-4, and that clinical trial is underway in the phase 3 clinical trial setting for patients who are previously untreated, so in the first-line setting for patients with metastatic renal cell carcinoma. So that phase 3 clinical trial has a combination of Nivolumab plus Ipilimumab versus sunitinib, and we'll wait to see what that data has. But there are other combinations that are being tested in the phase 1-2 setting, including combinations with anti-angiogenic agents or tyrosine kinase inhibitors, or even radiation therapy or cryoablation.
And that's it. Thank you for your attention.